And I'm at 12:01, so let's get started. Thank you all for joining us for this session. And I know that we haven't seen each other for about 6 months, and we were getting started and about to ramp up, and we had to take a break. But I'm glad to see so many faces back, that your enthusiasm is still here, because we're still very committed. And I will say that we've used this time to make our modules better and learn from all the online work that we've been doing. So we actually have broken up our videos into smaller chunks so that they are a bit easier to follow, and we have more narration to bridge them together so it's more clear. We won't have time to sort of where you're talking with your teams, because I know many of you are working individually and are not in big lunchrooms anymore. And we've, as always, we're recording everything online and post it on our website, which I'll show you again, in case you're not able to make this period live. But it is meant to be something to learn individual skills, but as a team. So welcome back. Again, if you require CME, please email your team lead and let them know that you're here. And let's get started. This is session 4 of Capacity. Okay. We're going to focus this session and actually next session too, because it's such a big topic about communicating to patients and families about serious illness. We have 2 faculty who are going to be presenting here. We actually have them recorded. Dr. Leah Steinberg from Mount Sinai, Aaron Gallagher from McMaster. They don't have any financial disclosures to report, and any conflicts of interest, they don't have that either. And this is a CIHR project. Okay, so before COVID, before the beginning of COVID, we went through steps 1, 2, and 3 of our 10 steps, okay? We focused on what you need for a strong team, and we spent the last 2 sessions in February and March, I think, about potentially the idea of creating a registry and identifying patients, the tools you would use to identify. So the next 2 sessions, session 4 and 5, we really want to focus on, now that you've identified them, how do you talk to them? How do you communicate what you're seeing with patients and families, and the challenges around that in primary care? So session 4 and 5, the objectives are really about evidence and tools, about communication, about serious illness, and the tips, strategies, practice supports on how you operationalize that so that you can actually do it right away, okay? And one of the things that we want to start with is maybe trying to paint a case scenario of what you might see, maybe once or twice a week perhaps, and the thoughts that might be running through your mind. So an 80-year-old patient has just returned from visiting their oncologist, or maybe was just discharged from hospital and was told to see you within the first few days. You're reading their chart and you realize, look, this person could potentially benefit from a palliative care approach, right? You use the surprise question or one of the things from your EMR trigger. So now, at some point, it crosses your mind, it'd be great to have a conversation about this, about what the future holds, but what does that mean? How do you do that? What do you say? How do you introduce this? Practically, how do you find time for this? So these are the kinds of things that we've heard from primary care providers at all levels that they might encounter. And so we want these 2 modules to be the thing that you can use that can help you do that. So the WIFM is the what's in it for me. So by the end of these 2 sessions, we hope that you will have more competency, more confidence in having these conversations, that you'll be able to strengthen your relationship with the patient and their family, who you're probably also your patients, and will continue on after when this patient passes away. Allowing you some skills to ease into the conversation earlier in the illness trajectory. That's the goal. So it's not crisis management right at the end and it's all rushed and stressed. It's about, what do I say about it earlier? And again, the no NASA rule, like, this isn't rocket science. You're probably doing many of these things already. We're trying to just remind you or highlight the things and how you weave them together. Okay, so these are the faces of those experts that you'll be hearing from in video format. Aaron Gallagher is a family physician at McMaster. She has a specialty in palliative care, so she does some consultation in the community. And Dr. Leah Steinberg from Mount Sinai is a in-hospital palliative care consultant, has done lots of teaching and training about conversations, and she has her own training modules, which we're picking up some of that. today. So these are our experts we're going to hear from. And as we show their videos, we've broken them up, as I said, and I'll sort of narrate in between them so we can weave them together in sort of a cohesive narrative. So where I wanted to start is just thinking about your own practice and how, you know, and your team members, what are the barriers that you could think about when you have this conversation? When you saw that patient, they come in, or they're, you know, 92 and they look healthy, but, you know, they're 92 and, you know, at some point, you know, things are going to change. So what are the kinds of conversations, what are the things you might say to introduce the conversation? What's going through your mind? So I just want to think about the barriers to doing that. And then this is a nice segue for Kayla to load up the first video, which is 2 minutes, just talking about some of the barriers that Dr. Erin Gallagher sees in her primary care practice.
Today I've been asked to speak to you a little bit about my experience with some of the biggest barriers that we have to open conversations with our patients and our families who are struggling with or facing life-threatening illnesses. And also to talk about some of the strategies and the tips to overcome this. Starting first with the barriers, I mean, I think one of the most obvious ones is just discomfort and lack of experience, especially for people who are new into family medicine. And, you know, in our training, so much of what we do is about comprehensive preventative and curative therapies and managing chronic conditions so people get better. And discussing things that are a little bit more ominous or more serious conversations certainly go against some of these things that have been so intentionally ingrained in us. We're afraid of being the bearer of bad news. And complicating this is, you know, the inconsistent messages that are then given by us and many of the specialists that are seeing our patients. They're often told if they go into, you know, the heart function clinic or the COPD clinic that they're doing great, you know, and that's the message that they take home. They don't necessarily understand that this is something that is going to get worse over time. There's also a general lack of knowledge amongst not just physicians, but the general public regarding why these conversations are important to be had early. And, you know, unfortunately, clinicians, going back to what I was saying earlier, they feel as though they need to have all of the answers when it comes to conversations like this. And that's impossible. Right? You know, we don't have a crystal ball. We don't know exactly how things are going to go for patients. And often it's hard to broach conversations that we don't have those answers. And then there's, you know, misperceptions in society. We live in what we've all heard as this death-denying society. And, you know, those with cancer are fighting the good fight, and we're just told to keep busy. And, you know, we don't deal with grief the way that we probably could and should. And then finally, there are things like time, right? In our practices in family medicine, we are busy. We are seeing patients and, you know, complex patients and different scenarios from a whole spectrum of care in a single day. And so to find the time and the energy for these types of conversations can be challenging, let alone the compensation models for them.
So perfect. So okay. So those are some of the barriers that we've heard. Are you guys able to see my screen? I'm hoping so.
Yes, we can.
Great. I just want to take a moment there. There were several, I'm sure it's maybe a couple of them resonated with you. The idea of this sort of, these two sessions is not, it will address those barriers, or we've heard from people who do this, that those are the things they used to encounter, and with these skills they are able to, you know, sort of manage them, not one off, but together, an approach that brings them. So the two things, because we haven't seen each other for quite a while, the two things that I really wanted to emphasize here are that when we're talking about this conversation, we're talking, and the idea of introducing the concept of palliative care, we are not talking about end of life. This is, we covered this way earlier, but just to remind you, it isn't an end of life conversation, like weeks, days. We're trying to, particularly in primary care, bring you not when their fingertips are at the water, but when maybe their knees are at the water or their waist deep, so you have time to prepare them for what's ahead. So that's one of the things. These conversations are, the earlier you do them, the easier it is to have the time to be able to manage the complexities that can happen. The second thing that comes up we hear often is there are these things that we think we're supposed to do in these conversations, like have an advanced care planning conversation, or talk about do not resuscitate and power of attorney and substitute decision maker. These are all these terms that cross our mind when we think of the conversation. And so I wanted to spend a few minutes just to put those into context. I think it's just like a 2-minute video to put some of these terms into context, and it's work that has been done in the province, provincially with a group that just kind of, it's a triangle of what are the levels of conversations we should have. So this is the framework, and Dr. Leah Steinberg is going to talk about it just for a couple minutes, and I'll finish up with some closing things.
So I've been asked to talk to you guys about some tools and tips to have these person-centered conversations to help facilitate and engage patients in these conversations. So let's just start with some basic definitions, because really what we're trying to do is work at improving advanced care planning and goals of care discussions. Advanced care planning is not about current treatment decisions. The role of advanced care planning is to prepare your patient's substitute decision maker for decisions in the future. And those discussions really should be focused on your patient's overall values and goals, not on specific treatments they might want or not want. It's almost impossible out of context to make those decisions. So make sure that your patient substitute decision maker knows your patient's values and goals. And what's really important is that this conversation happen between the substitute decision maker and your patient, because in the middle of the night in the emergency department, it'll be the substitute decision maker who is called for consent for treatment, not you or not your notes. And as we know, you can't have advanced directives in Ontario. Everything has to be consented to by the substitute decision maker. On the other hand, goals of care conversations, they really happen when a treatment decision is much more needed immediately or in the near future. And that's a much more focused conversation that has usually as an outcome a treatment decision. For example, if your patient needs to go on dialysis, or if they're wondering about starting an antibiotic in pneumonia if they have a very advanced illness, that would require more of a goals of care discussion. And then lastly, of course, consent has to happen for every treatment or care decision. Let's look at.
Okay, so like I said, a very short overview of some of the conceptual definitions of advanced care planning versus goals of care. And you could spend a half-day workshop, a full day with the serious illness conversation workshop, or you do role modeling about some of these. That's not the purpose of today. And in part because, the feedback has been serious illness conversation works great in hospitals, it's harder to translate that into primary care. It looks a little bit different. It looks very different, actually. So what I wanted to just flag for you, besides this triangle, is that there's a speakupontario.ca. Obviously, there's the Speak Up National program, which links you to national tools about having these conversations at various stages. But there is a working group in Ontario that has created tons of materials. They've done these talks before. You might have attended some. But they have this little picture here, sort of a decision tree of which conversation are you having depending on, do they have a serious illness? Is a treatment decision being made, and can they consent or not? Okay, and so the legal aspects of this, I've heard if you sort of understand that, it helps you to have these conversations better. Again, we're not focusing on that today. The other framework they have if you go to this website is they have this sort of placemat, so to speak, where depending on which one, what is your tasks, what tools do they have, and that kind of thing. Okay, so I just wanted to point you to high level that this can be very technical. And there are resources out there on this concept of advanced care planning and goals of care. And a lot of this, as you can see, is built on serious illness conversation, but other modules out there. However, for primary care, what we've heard time and time again is that when they're for the people who do this, when they're trying to have this conversation, they're not thinking about the technical legal parts of it. It's like when someone has a serious illness, this analogy, I sort of came up with, but I think it works, is that when someone has a serious illness, their family and that patient, they sort of are on a trip. They want a trip, whether they liked it or not, and they get into that car. And we hear, or I hear when I do my interviews from patients and families, that they often feel that they didn't know where they were going. They did not know the journey. They didn't know the destination, the final destination. They didn't know what lies ahead, the twists and the turns. And so what I'm saying is, for primary care, the role of the team, any of the providers in that group, is to be sort of like a tour guide. And depending on your relationship, you know, maybe you feel like you're the driver of the seat or your friend along in the car ride, but you're sort of the tour guide. Your goal is to help explain the big picture of the illness. Where are they going? What, if they don't know where they're going, they didn't know what to pack. They didn't know what to prepare for. They didn't know what to be looking for when they're looking at the window, those kinds of things. And I would say this concept of advanced care planning and goals of care discussions, they are specific conversations at pit stops, at rest stops. You know, along the way in any long car ride, you're going to take rest stops to eat and, you know, take a break. And those are good opportunities to have these conversations. But the goal of these conversations is not to get to these, you know, consents or, you know, check off these boxes and fill out these forms about do not resuscitate or what have you. The goal is to help them understand and prepare for what's ahead. And so I think if you have, you know, you're toggling between those two because you also are the guide for those rest stops, you know, you're the tour guide, here's our stop, you know, get back on the bus in 30 minutes kind of thing. But you also are trying to help them see the big picture of the illness and the whole ride along the way. Okay, so that's my little spiel there. And so to help with that, this is the framework that I think is much more useful, not that pyramid, for primary care. It is, and we're going to cover this whole thing across the 2 sessions, session 5 next week. The rest of this time, we're just going to focus on the green box and the orange box. Okay, and so I think I can pass it to Kayla to what we're just going to spend maybe 5 minutes on the green box. Prepare yourself. That's the first step.
Let's look at what I think of as the sort of generic model for having any of these conversations. There are many workshops. You can take the serious illness conversation, for example, and really they all focus on this kind of a similar flow. The first is to prepare yourself, and the rest of this talk, what we're going to do is spend some time on each of these. The next, probably most important one, is to explore your patient's illness understanding. Once you know what their illness understanding is, you're going to provide illness education, if possible, if it's wanted. Then you'll explore your patient's goals and values. And lastly, based on all of this information, you'll create a plan. Now, the most really important thing is that this is not a linear process. You're going to move around as you get comfortable with these conversations, and you're going to flow from one to the other. But the other really important thing is to realize that these conversations are really ones where you want to stay as open as possible to your patient's own understanding and goals and values. This isn't a conversation where you should have a specific outcome in mind. Okay, so having said that, let's move on and let's look at some important things when you're thinking about preparing yourself. The first thing is, do you know about the illness? What we're really talking about are patients here who have an underlying illness. We're really not talking about advanced care planning for healthy patients. So in this case, many of these patients will have an underlying illness. And one of the most important things is to make sure that you're aware of what's happening. That might mean connecting with their specialists. And I have to say, in my experience, I connect a lot with patient specialists, and it's always a useful exercise. They want to talk to you, and you can get on the same page. Patients can really end up with mixed messages, and that's worse than no message at all, I think. And lastly, and I was alluding to this before, I think we get ourselves a bit wound up and a bit worried about these conversations because we think there's some agenda, there's some goal that we really want our patient to achieve, whether that's, to sign DNR form, or to say goodbye appropriately, or to do things that we want them to do. And that, I think, creates a lot of stress on providers, and it shares that distress with the patients. Really, I think the way to think about this is purely a guiding, open conversation with your patients. You're going to offer them this. And as long as you're following their lead, it will most likely be a useful conversation, and you'll learn that they're really not that hard to have. Again, related to this, watch your expectations. Remember, this is, for some people, significant behavior change. And we all know the Prochasta stages of change model. And think about advanced care planning as following this kind of model. We know from data that about 20% of your patients will take an invitation to do some advanced care planning, and they won't need anything more. They're going to run off with it, with the booklet, and they're going to go and deal with this. And another 20% probably aren't ever going to do it. And then the group in the middle may need a little bit more encouraging over time. But this is the important thing, is to realize you only need to take a step at a time. Now, the question is, when should this happen for your patients? And I think it's important to have some specific triggers that work for you and your clinic. Clinics are busy, you're pulled in many, many different directions. And in the moment, it's going to be probably impossible for you to think, oh, I need to start to talk to Mr. Smith about the future. So there should be some regular triggers you set up, whether that's recent hospitalizations or a visit to their specialist, a significant change in their medication. But even more important, just try to listen to cues from your patient. There will be lots of opportunities that they'll bring up, because most of people we know want to talk. So now, once you've decided that this is the patient for the conversation, how do we open up this conversation? Well, here's one example. You might say, Mr. Smith, I want to help my patients understand that they have a serious illness and that they need to plan. Have you talked to anyone about what you would want if you were too sick to talk for yourself? So I don't think there's anything terribly bad with that introduction, but I do find it a bit practitioner-centered. It's more about kind of that I think you need to know that you have a serious illness. And I think that can be off-putting for a lot of patients. If you think about it, nobody would sign up for a serious illness conversation, but they might sign up for having better understanding of their illness and having more control over decisions in the future. So how about something like this? And this is the kind of thing that I might use for people, because I want to sort of own the fact that I think it's important and be really clear about that. And then give them an opening and an offering. So I might say, an important role for me in your care is to make sure I'm helping you with the challenges your fill in the blank is presenting. That seems more something a patient might be interested in. Or you've had fill in the blank heart problems for a while now, and usually I talk with my patients about the overall picture, but we haven't really done that. Would you be interested in that? Or in my experience, most patients want me to discuss what might happen in the future with your illness. Others don't want that kind of a conversation. Tell me about you. How can I be the best doctor for you? That kind of approach, I think, is much less threatening, is a lot easier for us to do. Having given you these ideas, though, I think the best thing is for you to create some phrases that work for you in your own practice. Feel free to steal these, or do anything. These are not in any way mine. I've learned this from lots of other people. And now.
Okay, so I'm gonna make sure. So we just covered this green box. And so I wanted to just take a moment here. We have over 85 people on the call. Let's just take a moment to just pause and just think about some of the things that Leah just talked about in this framework for preparing yourself. Do any of these things that she said resonate with you? Do any of these phrases are things you might like? I think what we might do is we have a little bit of time. So if people want to put something in the chat box, it'd be great so that we can at least read some comments if you have questions. But I just wanted to give people a moment here to just let things sink in and have some dialogue potentially. Okay, I'm seeing not a lot of people chatting, maybe people are shy, but that's okay. We do want to try to make it interactive. Oops. I will say the big light bulb for me in this, besides some of the phrases, is the idea of not having an agenda. I thought that was sort of maybe that's obvious to you, but when I hear a lot of this, especially in the hospital setting where a lot of this education is coming from, they do have an agenda. They're trying to get people out of a bed. They want them to fill out a DNR. But in primary care, I feel like if you want to go upstream, there really isn't this idea of there is a goal in mind. You're offering education, maybe the Speak Up booklet or the invitation to talk about what's ahead. They may or may not take it, and that's okay. And knowing that's okay, and knowing that you're not supposed to have all the answers when you're just guiding them and offering the conversation, that's really the job. So anyway, to me, that was really important and very different and unique to primary care. That may be different. Okay, I see some people typing in things now. Maybe I'll just give another minute and then we can move on, and maybe Maggie can let me know if they're, if you want to read any of the comments.
Yeah, so I have a comment here from one of our registered dietitians, Jenna, who says that she finds it fairly easy to start by asking what their goals are for their care treatment with respect to food. So that's an excellent way to relate to like your role. And then another comment here from Richard, like the way of phrasing to change, the provider is there to help them.
Yeah, it did resonate with me. The serious illness conversation is the first one that I want to help my patients. And then the other ones are other things that Leah uses in her practice. Okay, well, I hope the idea is for you to maybe share some of these phrases, these tips, which are sort of the how-to, right? Not just the conceptually, I understand, I need to prepare myself, but how do I actually operationalize and do this in my practice? These are the tips from sort of people who are doing it in the field for many, many years. This is what they say. Okay, so let's move on to the next box, which is the orange box, the illness understanding. And it's about 8 minutes, but I think Leah said this, and it is probably one of the most important parts of the framework, because if you don't get this part right, if you're not understanding where they're coming from, it always sort of comes back to bite you. So I'll pass it over to Kayla to set up the video, and we'll just chat after.
And now we're going to move on to the second, which, as I said, is really probably the most important. Getting somebody's illness understanding is essential, because if you can imagine one patient says to you, well, I have breast cancer, but I just need to get stronger because the oncologist has told me that there's more chemo if I can get stronger. If that's their illness understanding, whether or not it's true, if that's where they're coming from, you're going to have a very different conversation than if somebody says, I have breast cancer, my oncologist doesn't want to give me more chemotherapy, and frankly, I'm too tired for it. What I really want to do is figure out what to do from here. So if you don't have that information at the beginning, you can really you can end up going down a path that isn't very helpful. So because I work in acute care, I actually think it's a little bit easier for me in that I don't know people in advance generally. So I can come in kind of fresh and say, I've read the medical chart and I know usually what I say, I know what the doctors have written and I know what the medical information is, but it helps me to know what's happened from your perspective. So for people in clinic or with longitudinal patients, it can be a little bit harder because you already have this ongoing relationship with them, and to sort of suddenly stop the typical flow in your clinic, which is often, adjusting medications and talking about preventive health. And there's a bunch of other things everybody has to do. You need a way to kind of break that cycle. So, you might do something like, I read the report from when you saw the cardiologist last time, or when you saw the oncologist last time, or, I haven't been getting a lot of reports. Tell me what's been happening with your care. So that is a way to sort of maybe break into the typical flow of a clinic. You have to kind of, there's a change in the flow that's needed. Once you've started though, I think what's really important is to realize that during exploring the understanding, you really want your patient talking more than you. This is not about correcting their information or anything, but really trying to understand their understanding. And oftentimes it takes a little longer than we think, because people won't just blurt out the honest truth right away. They're not sure they can handle it. They're not sure you can handle it. They're not even really sure that that's what you want. So I think you have to expect that this can take a little bit of probing. So I have 3 things that I use all the time. Open-ended questions, and you guys know all of this, but I've got a couple of examples that I really, really like. One is, I might say to somebody, you know, as you think about the future, what worries you the most, or what worries or concerns do you have? I might ask, what does your family know about your illness? And then lastly, it's always helpful to just ask somebody why or what's behind that. The more you explore this, the more useful the information is. So that's that step. Then another way to encourage them to talk is to use a reflection, which we learn about when you study or when you learn about motivational interviewing, is to really just repeat the last thing that they said and then wait. And that will encourage people to expand on what they've said. And then lastly, silence, which I think is probably the most important skill we have and probably the least practiced. Silence feels uncomfortable for us, but it doesn't feel uncomfortable for your patients generally. During a silence, patients are actually thinking about what to say and actually letting themselves feel some of the emotion that maybe they haven't allowed themselves to feel before. And so it's actually very important work during silence, and it's a good skill to practice. A couple of quick pearls. If you're struggling, if the patient seems to not really feel comfortable opening up, or they're kind of circling around things without getting into what you think they already know, I find it's helpful to ask what their family knows. And often people won't talk about what they know, but you know, if you say, tell me, have you and your wife had an opportunity to talk about what's happening? Usually they're more comfortable talking about what they know when they're talking about what their wife knows or their kids. Or you can ask about their functional decline. You know, I've noticed that whatever has changed. You're coming to the clinic now in a wheelchair. What do you think might be going on with that? So those are different ways if you're struggling. The most important thing here is to really learn that this is an exploration of your patient's understanding. You don't want to judge or correct them. You want to use, again, this comes from motivational interviewing, unconditional positive regard. You want them to feel very supported through this. It doesn't mean you're going to agree. It doesn't mean that if they have a very wrong understanding or misunderstanding that you're agreeing. But it's that you're going to be very open to what they have to tell you. So leading up to that, lots of times we'll get consults for people and we'll be told, well, they're in denial, or you know, they don't understand their illness. And the fact is, when I hear that, it's a pretty big red flag. True denial is actually very rare. And in fact, if people are pushing back on discussing information, or they don't want to talk about what the future is going to hold, most of the times it's because they actually have very good illness understanding. They just aren't ready to talk about it. They're not ready to have it out in the open. And so really ask yourself, is this really a knowledge gap, or is it an emotional gap? And I find that what happens is, when it's an emotional gap, they're just not feeling safe or safe within themselves to talk about something. If we forget that it's an emotional gap and we assume it's a knowledge gap, the risk is that we talk to an emotional gap, we give them more information, or we reinforce again, well, you know, the oncologist did tell me that she doesn't feel like there's any more chemotherapy. Well, if you're talking to a strong emotion or somebody who's not ready, then providing more knowledge just to actually brings their defenses up even more. So it's much more important to say something that addresses the emotional gap, something like, it seems like it's really hard to talk about this, or have you been able to talk to anyone about it? I can't, it seems like it's a very difficult topic, or anything like that that actually speaks to the emotion as opposed to the knowledge. Often what can happen is you will actually end up with somebody having strong emotions right there with you. And that's actually okay. That's actually a really good thing, because that's where the work can happen. One of the reasons that people may be seeming to be in denial is that they've been terrified of the emotions. And if you're able to provide a safe space while they have some of those emotional reactions, then that's the best thing you can do for them. Sometimes though, when we end up with somebody with a strong emotion, we tend to do a couple of things. We tend to reassure them prematurely. I'm sure Dr. Smith will come up with another way to fix this, or we backpedal. All right, so let's see, let's go back and do some more blood work and see. So we get ourselves scared when they're saying things like, I can't believe this is happening. This can't be happening to me. And we get very scared and we say, well, maybe we can find something else. Instead saying, you can stay with them and say, it's unbelievable, isn't it? Give them just a little bit of reflection so that they can stay in that place. The other thing to do, and we rarely do this for patients, is give them positive feedback and support. And so you can say something like, you've told me what's happening, and I'm impressed with how well you understand what the doctor's been saying. So that's a really nice way to both reaffirm for them that their information's right, and that they are okay, and that they're managing very well.
In my practice in family medicine.
Okay. Okay. So there was a lot of information there in this orange box about the illness understanding. We have a little bit of time. It would be great if we could have a little bit of discussion here. This is a great opportunity to do that, where we could, the question and the reflection is, did any of the concepts, were there any light bulbs or mini light bulbs that went off, Christmas light, the mini ones where you're kind of like, oh yeah, that makes sense to me. I've had that happen. And any good ideas that you could take away. That's what we're hoping. Or any that you might want to adapt, or any questions you might have. So I think we can try on the chat, but if that's not working because we're not a chat box kind of group, we could try, we have about 10 minutes, so we could also try to unmute yourselves and we could talk about it as well.
So there's a comment in the chat, Sian, about using silence and how that can really bring some comfort to the patients and family.
It's so bizarre. It just seems to unmute randomly.
Go ahead, Maggie.
So Mike started to type a comment in here, and I wonder if I can invite you to speak up about the emotional knowledge gap that's the most interesting for you. As in long-term care, most of the interaction is from the power of attorney. Do you want, I don't know if you want to, I don't want to put you on the spot, but if you want to unmute and talk about your experience, maybe others might be able to resonate.
Hi there, you can hear me okay?
Yeah, you're good.
Yeah, no, for sure. I find 90% of, so it's a difficult conversation with me only because I expect, as, in my person-centric practitioner way, that when you come to long-term care that, they've had this conversation before, or they know that, this is the place that they're going to pass away. And oftentimes that I find I have conversations with families and they're very angry and not accepting of this fact, and or long-term care is a place where people are going to rehab and do better and possibly leave. And you know, I know it's,
Look at it saying to me, "Hi, Steve. As host, we are muting."
Their understanding, and you know, the fact that, right, we don't die and people, they want their loved ones to live forever. But just the words of in the reflection that you had, you know, the emotional gap versus a knowledge gap, I find that is probably the emotional gap, is that people just don't want to accept. And I find there's a lot of turmoil related to that. And over time, that mostly gets better with multiple conversations, but there's always some that, have a bad death, not necessarily the person that's passing away, but it's the family that are not accepting of it until the person dies suddenly, and there's really nothing that you can do. But that's not as common. But I think it's the emotional gap piece that I think is the hardest one for myself to help people over that spot.
Thanks, Mike. And I think part of Leia's point was that our job is not to solve the emotion. It is to be there with them. And if I'm just listening to what I know she's not here, but was to just, that's where the work happens, when they can embrace that emotions. Because part of what you're saying is this is the first time where they're able to really unload or to face those emotions in a safe space. So I think part of it is being okay with that. Yeah, they're going to have emotion, like cry in front of you, and what I was trying to practice, and it's so hard to just stay silent and not say something, and not just sort of backpedal and go, oh, it's going to be okay, or I'm sure it'll get better, or whatever, things as human beings we might want to say. It is to kind of put them forward. Just to link to what you also said, next session, where we go into the blue box about education. This is where we, and you might know some of these tips and tricks of the statements of what we say after we get into their illness. And once we understand their illness understanding, then there are, I wish, I worry, I wish that, it's going to be that you will be, find remission again, but I worry that this and this. And so I think, and the other piece of it is, if we do this more upstream, the more time we have to not be so unprepared, the more time we have to prepare them for the possibility that these things could happen, and to get things in place so they don't feel so let down. So I think all of those, they all go hand in hand with more time and opening this conversation earlier.
Yes, and there's another comment in the chat box from Richard about recognizing that silence is important for example, people from First Nation communities, and to give people time because it takes them longer to respond. And I think that recognizing cultural difference is also very important. So I don't know if anyone else on the line has any advice or experience with that they want to speak about. Or Richard, if you want to add more.
So I'll just say that this is session 4. In session 6, we talk about the actual assessment, and we have another guest who talks about how she makes time for this in our practice. And one of her tips, and I'll just tell you now, but you'll be reminded again in 2 months, is she knows that these patients are coming in, and she books them in at the end of the day. So she tries to do a 30-minute appointments, because to give people time to have to be able to have a longer appointment, and allow them the time they might need to just sit in silence, or to, have a longer conversation. So that's one of the tips that many of them say they do when they, these patients who you want to have a longer conversation or introduce this, they book them at the end of the day. Okay, let's keep going. But I mean, the goal is to present different speakers who have experience from primary medicine, but also outside, and hopefully offer you, the best tips and tricks that you can adapt and put in place in your own practices. But when I looked at this isn't just about illness understanding. This applies to, me talking with my daughter about, how she shouldn't punch people or whatever. It is all, this framework works for many different things. She doesn't punch other people. I was just trying to, anyway, okay. Okay, so I wanted to just give the last word for these presentations to Dr. Erin Gallagher, and she was going to, who's our primary care family physician, to just talk a little bit about how she does these tips when we start, which is a nice segue from what Richard was saying. So I'll turn it over to Kayla to it's a very short video, and then we'll wrap up.
In my practice in family medicine, I have found that there are actually ways to have these conversations much earlier when things are not so acute and scary. So when patients are approaching end of life, of course, they're going to happen, but there are other times that I find that we can do this. And that's, certainly at a time of a new diagnosis and not even knowing that it's terminal yet, like cancer. I have a lot of older patients that come into the clinic wanting their annual physical, and they're worrying about getting older, and you recognize this worry in them, and they see a change in themselves. And so, just asking them, what is it? What are the changes that you see in yourself, and what does this mean to you? And what do you worry about these changes, how do you worry about these changes affecting your future? And it actually opens up a lot of room for pretty fruitful discussion about what's important to them and things that they would or wouldn't want in the future. The same topics can happen after somebody has lost a loved one. Even just asking them about what that experience was like for them can be really eye-opening about the things that are important to them and things that they themselves would maybe want to avoid in the future. And then, it's important to note that these are not static conversations. They are ones that happen over time and they evolve, and it's important to revisit them as time goes on through subsequent visits.
Okay, if we have time at the end, we can absolutely open it up to open discussion. I just wanted to make sure that we keep you on time. But I think the overarching thread is it is very different than serious illness conversation, which really feels like you're trying to get to a decision and a plan. At least in these opening steps, it's really offering the opportunity for them to talk about what they have. So what we've learned today, that framework of the pyramid about advanced care planning versus healthcare consent and goals of care, this overarching framework for having a quote unquote conversation, which started with the green box, prepare yourself, and the orange box, illness understanding. We'll finish the rest of the framework in next session. And you're learning to prepare how you have a conversation and explore their illness understanding. Some of the phrases and tips and tricks that people who do this a lot have used. So our 30-day challenge for you is, as I said, Dr. Leah Steinberg's been doing this for over 10 years. She has a website, it's free, it's goalsofcaremodule.com. And it's sort of like a self-learning thing, if you have lots of time, you can do, or more time, if you're very interested, you can do, go through from top to bottom. But we just want you to watch, if you only have 10 minutes, the Mr. Young video, because I felt like when I watched that was, the biggest light bulb amongst all of them about this idea of, oh, I really thought this person didn't understand, was not prepared to have the conversation, and watching how Leah uses her techniques in action allowed them to open up the conversation. So that's our 30-day challenge for you. It's actually one of the easier ones. And again, this isn't only for the physicians or the nurse practitioners to have this conversation. These are skills that anyone on your team could be able to have. And I wanted to remind you that all our materials are posted on our website, palliativecareinnovation.com. There's a tab called Capacity. If you click on that, it brings you to the steps, and this is session 4 and 5. So just so you know, right after this, shortly after this, in the green arrow, this whole thing has been recorded. It will be posted there, so your colleagues and yourselves, you can rewatch it or what have you. We have the slides of session 4. That's the top orange bar. The second one is the 30-day challenge, which I just told you is watch Mr. Young's video. And then we created a cheat sheet. It's a 1-page, front and back. It looks like this, and you can download it and you can see the tips for that framework. And hopefully it's something you can take away that will help remind you some of the things and the phrases that you can use in your own practice. So the next steps are, if you want, download the cheat sheet. I think would be helpful as a reference. the 30-day challenge, watch Mr. Young, or learn more, and you can sign up from any of the websites you checked out. If you have any questions, email your facilitators or myself at any time in the next month. We have an end of month, so at 28 days from now, we'll send you an evaluation of how this session went, and watching Mr. Young and any of the tips, any of your experiences. And we will, we will also have an evaluation right here in the webinar in like about a minute. But I just wanted to walk you through the appendix, because there's always an appendix. We don't always have time to go through, but very quickly, in our appendix, we have the literature that we've cited if you wanted to read more. These are websites that have all the materials on them, the goals of care module, which is where your 30-day challenge will come from, but also Speak Up has actual workbooks that I know people put in their office. So when they have the advanced care planning conversation or introduce this, some people like to pass that on, and they say, look at this and come back next time, we'll have a more deeper conversation about your goals and values. And these are some other resources, and some of, the serious illness conversations at the bottom, but Jeff Myers has done stuff on advanced care planning. There's the 6 Breaking Bad News. There's various other resources that might be helpful if you want more practice or more tips from other places. Conversation Project, etc. Power of Attorney, that came up, so there's some information there. Oh, and there's online courses. You can take additional training that's like half day or full day. The serious illness conversation is one where they have role play, and then the Speak Up e-learning modules where it's self-directed. Again, more videos. Okay, so you can see, and if you are following the OPCN's Palliative Care Health Services Framework, delivery framework, this, where I circled it and highlighted in yellow, is really how that connects. And if you're a clinician that's trying to get additional CME credits, we sort of help give you some language that you might use. Anyways, we won't always have time to go through the appendix, but this is what you would find in the appendix of our slides all the time.